I'm Jim Rudolph. I'm a geriatrician and palliative care physician who spent a long time implementing delirium programs. I'm here today to talk to you about changing delirium practice. And I think it's important for everyone to understand that as we're implementing delirium practice, we plan and we do, and what's in between is a lot of learning that goes on. And that learning could be described as blundering, it could be described as mistakes. I think it's just part of the process. My overall goal here today is to inspire you to implement a successful delirium program. And I'm going to do that by showing you how I've made big errors along the way. All of us know that delirium is complex. And the goal in implementation is often simplicity. And so the two seem juxtaposed or unable to be reconciled. That's not necessarily true. There's things we can do today to help with delirium. I have found throughout my career that at every institution there's one, maybe two people who are really passionate about delirium. They're complex people and they have different motivations for why they care about delirium. But one person alone in an institution really struggles to make a difference. We also face a challenge in that delirium is low priority at most of our institutions. When you look at the coding and how we're being reimbursed, delirium often falls to the bottom of the list relative to some of the more better known complications. There's a strategy we can use though, and that is to find people with common interest. It happens that a bunch of excellent researchers have done work over the years that have found that delirium is associated with some significant negative outcomes related to hospital patients. That's bad for people who develop delirium, but it's good for those of us who study delirium because we can develop collaborations with teams that are studying falls, restraints, length of stay, costs, readmission. All of those are things that hospitals do care about, and we have to build together to do that. The first blunder I did was to start really, really big. And so we pulled together a committee and we were all ready to go. And what it ended up being was a series of endless meetings. The great part was everyone was represented. The bad news is that in that huge complexity, no one felt empowered to do anything. And so it really led to a lot of nothingness. And after a lot of discussion and a report, what came out was that we were supposed to form another group to look at it, another task force. And so we ended up in a series of other meetings. My second blunder is to think that lectures change practice. I was trained in a very academic pathway. And it turns out that when you talk to people, that doesn't change practice. We actually need to give them steps for action. Here's some examples when we were implementing our delirium program of how often we were out talking to people and giving education. We did lots of grand rounds, we did lots of in-services, and we did lectures, and that's not the total of the one-on-one teaching we also did. Lots of time and energy spent in delivering delirium education with pretty limited clinical impact, and I would say zero clinical impact. Another area where I blundered was to think that people could do more work. We know in healthcare that we're all pretty stretched. And this has been exemplified during COVID times when we really are stretched to our limits as to what we're doing. So just one more little thing is a big deal to someone. My example of this is we wanted nurses to do a delirium assessment upon admission. And we went through a lot of time, developed trainings, built it into the nursing scope of practice, and tried to get nurses comfortable with the prospect. And in the end, Not a lot of nurses did it because it wasn't in their best interest or their patient's best interest. And so we spent about a year and a half trying to implement a delirium nursing assessment that didn't work because we were trying to pile on additional effort. What we did find worked was trying to streamline processes in the hospital. So taking complexities and saying, hey, if you're going to do this at all, here's where you focus your energy. The first example I have of that is our electronic risk stratification for delirium. We developed a strategy and validated a strategy where we took existing known literature causes for delirium and we coded them into our medical record system and built this coding algorithm that then put forth a dashboard so that people didn't have to go to the place to everyone to get their thing. It was a fairly focused assessment that they could do. Our delirium prediction rule worked okay. It got better if you did some in-person assessment, but that was the whole goal, is to direct energy to the patients that needed it most. Another example of a streamlined cognitive process was our assessment for cognition. And we had read the literature, and the literature supports very much standardized cognitive assessment and then a delirium algorithm or delirium diagnostic pathway. And that's great, except that takes 15 to 20 minutes of effort. And nurses, physicians don't have that to give per patient. Think of this, a 15 to 20 minute assessment on 8 patients that a nurse is caring for. That's roughly 3 hours per shift that we're expecting that nurse to devote to delirium assessments. It's not going to happen. So we took a different approach. We went after very rapid cognitive assessments, also that we could utilize in other areas, particularly in sedation scales and falls assessments. So we built this strategy, and our monitoring strategy for delirium became a one simple instrument, asking the patient how they're feeling today and scoring whether they were able to respond to you or not. And that one simple strategy has now been, was fairly valid in our population. Again, it doesn't pick up everyone, but it picks up a lot of people and probably most people. And if you track it over time, it does a much better job of picking up people. Subsequent to our work, that's been validated in a number of studies. So we're comfortable that this rapid assessment for awareness is really actually a fairly good screening tool for longitudinal changes in cognition, which is a core criteria of delirium. It also helps, going back to the first part about developing collaborations, we know that changes in our RAS, when combined with changes in attention, that gets us most of the way to the delirium diagnosis. And so months of the year backwards was our delirium or our attention assessment. And the assessment that we delivered here is pretty sensitive and specific. Look at what happens when we look at restraint use. And we had a restraint reduction committee. We could go to them with this information and say, hey, our assessment is going to help you determine who's going to be in restraints, and it gives you an opportunity to put your attention where it's needed most. It also helped our case managers and our care planners for what happens beyond the hospital. If you have an abnormal level of arousal and you can't do the months of the year backwards, less than half of those people are going to go home. So we might as well be engaged with them early on in the process. It also helps predict mortality of who's going to die in the hospital. It's a quadrupling of mortality, and that's a high-risk group for sure. I don't know exactly what we would do about it, but the hospital did care about their mortality statistics. All right, another blunder I tried to make is thinking that we could do assessments, take the data from those assessments, use the data for ourselves, and not leave another pathway for nursing staff to engage with the patient. What we did to counter that is we developed something called the Delirium toolbox. And the Delirium toolbox is a physical toolbox, and it's got stuff in it to help with sensory improvement, so portable hearing amplifiers, magnifying glasses. It has stuff to stimulate patients cognitively during the day. Crossword puzzles, word searches, playing cards, games, things like that. And then it has items to help with sleep promotions, earplugs and eye masks and soft music. What we found is that when a nurse went to the Delirium toolbox and handed something to the patient, that those patients did better during their hospital stay. And they had a reduction in length of stay of over a half day. They were way less likely to use restraints. There was a modest impact in mortality. They were less likely, or they were a little bit more likely to go to rehab. But it saved us about $1,400 per day, per item in the toolbox when we handed this out. It was a great investment. Which leads us to our next strategy. Strategy number 5 is not getting stakeholder support. When you're going for your implementation, you need both grassroots implementation strategies and you need top-down. So grassroots are your frontline caregivers, nursing staff, nursing assistants, pharmacy, dietary, all the people who are engaging with the patient. And then from a top-down standpoint, you need leadership and administration to be on board with this project so that when it's successful, they will consider sustaining it. I'll tell you a story. So we had completed our project. We had shown a $1,400 savings per item when we delivered items from the Delirium toolbox. $1,400 per item. That's pretty good. Good evidence to support what we do. You know, we weren't the first to say, hey, improving people's sleep and improving people's cognition is the way to better outcomes for older people in the hospital. Anyway, I presented this grand rounds. The entire hospital came out for the grand rounds. And at the end of the grand rounds, our chief of medicine stood up and said, "This is great work. This is really great work. We're going to buy a box of earplugs for every ward." Not remembering all of the education, the training, the engagement, the investments that we had made in there. It was a real blow to me in my program that I hadn't spent enough time getting in stakeholder engagement from that top down so that we could support something like this after the program was done. The other thing that I want to share with you is that delirium is really serious. And if you read the literature on delirium, most articles start out with this concept that delirium is really bad, and it's extremely bad for patients in terms of mortality and functional recovery and cognitive impairment. And that's true. But the reality is there's so few of us doing this that unless we engage people in a different way, selling it through bad statistics is going to be really, really hard. Break in World Delirium Awareness Day. And I want to point out something. This is our 4th World Delirium Awareness Day. And we have tried in World Delirium Awareness Day to make it fun. So in our first year, we were just building and getting towards that. In our second year is when we started to talk about superheroes. So I'm wearing a shirt today that says Delirium Superhero on it, trying to make it fun for other people to engage in delirium. The other bigger blunder that I can think of is going at this alone. I already mentioned how we're alone in our hospitals often as delirium champions. And so there's a real opportunity to engage with people who have gone through this process before you. And regardless of where you're at in the world, we've got a society for you. So we have the European Delirium Society, we have the Australasian Delirium Society, and we have the American Delirium Society. And my pointing is a little off. So I hope you have fun and engage on World Delirium Awareness Day. Thanks for being part of it. And I look forward to next year when hopefully we won't have to be wearing these silly masks. Thank you all.